John Berk is the assistant director of the Amyloidosis Center at Boston University and has been a regular speaker at this conference, a really magnificent amyloidologist, has really committed his entire career for the care of patients with amyloid, and unfortunately he was not able to attend, but his topics, you can start the slides, was important enough to be presented, but I assure you that what I'm going to tell you is entirely his work, important as it is. So can we start the alternative treatments? Oh, do I do that? Thank you. No. So, good. This is Professor Berk's presentation. Good. And again, amyloid is a neurologic degenerative disease, like so many other neurologic diseases like Alzheimer's and Parkinson's disease and Lou Gehrig's disease. And much of it is related to the degeneration due to damage from fibrils. And there's some commonalities between those that can be considered for the treatment of amyloid. Many of these really aren't studied, but they all have in common oxidative stress, where oxygen actually damages the protein. Your cells are in a continuous struggle to eliminate free radicals, which are the source of this oxygenated stress that damages the cell and the proteins. And those can lead to both cellular inflammation and cellular death. So attacking that oxidative stress is at least a potential mechanism to manage some of these common disorders that all end up in neurological degeneration. So some of the things, and again, these haven't super studied, but have been proposed, and these are polyphenolic nutraceuticals. These are generally over the counter. They're not regulated by the FDA because they haven't undergone the type of rigorous studies, but that includes flavonoids, and of course that means diets that are high in fresh fruits and vegetables, whole grains, teas and wines, which I'll get to. And these have been studied primarily in the Alzheimer's space, just reminding you that Alzheimer's disease is also a form of amyloidosis. In fact, the very first use of Congo red to diagnose amyloid was actually in Alzheimer's brain in 1918. And those agents have shown an effect in Alzheimer's disease by limiting the oxidative injury. And we're talking primarily about TTR. Amyloid's different. It's an A-beta protein, but it actually destabilizes the formed amyloid fibril, and it inhibits the activation of the white blood cells that are responsible for attacking and destroying tissues. Curcumin, which is used a lot in multiple myeloma and AL amyloidosis, is an active spice of turmeric. This also has been shown to have value in the test tube against amyloid, but not much evidence in human studies that people take it. Reversitrol, there's always been this common assessment and belief that a glass of red wine is good for your heart health, reducing coronary artery disease. The active extract in red wine is reversitrol, and this is also available over the counter at most of your general nutrition stores and has been used for prevention. And then EGCG, which is the active agent in green tea, also has profound antioxidant potential, although by my estimates, it takes about 12 gallons a day to get the levels that are achieved in the test tube, but that doesn't change the fact that many people have adopted green tea for its antioxidant properties. That's not to say it's been proven to be beneficial in these disorders. In the upper left-hand corner, you can see the EGCG. So that's the green tea, and the left is the curcumin spice, and the reversitrol in the upper right-hand corner, the red wine. And all of those have been applied in not very well-controlled studies for the prevention of neurodegenerative disease. So this is not a recommendation, but just a recognition that individuals and scientists are trying to establish potential benefit of these supplements. So curcumin, which is the spice, inhibits the aggregation of Alzheimer's amyloid and actually breaks up amyloid fibrils in the test tube and actually blocks the damage that the amyloid fibril toxin does to brain cells. TTR, as you know from our very first talk, functions normally in the body as a carrier of thyroid hormone. And curcumin actually competes with thyroid for binding in the central pocket of the TTR molecule, and in animal models can promote the more rapid clearance of aggregates of TTR and can have an effect on fibril formation. Now, this has not been well tested in humans. Most of this is animal research and test tube research. And it penetrates the blood-brain barrier. So at least theoretically, potentially, there might be some role for people who have inherited leptomeningeal TTR amyloidosis. But it has to be taken in very large doses because its absorption is very, very poor. This is just some of the published studies demonstrating how curcumin, again, this is animal models, decreases the damage that ATTR produces in the nerves of mice. And the way in which it was done is a curcumin, this spice was put in the drinking water of mice. Placebo mice didn't get the spice. Hard to achieve levels and was hard to match with the human disease, but some evidence. You can see on the left, the brown is the amyloid. And there's just more brown on the left than on the right. Resveratrol, again, is what is found in red wine, and it does stabilize TTR, and it also aggregates some of the toxic TTR monomers that damage cells, and in mouse models has been shown to be effective in Alzheimer's amyloid and reduces the oxidative, those free radical damage to the brain cells in patients with Alzheimer's. Again, you have to take a lot of it because it's absorbed very, very poorly, and no one knows what an effective dose is. And human trials haven't been conclusive to date, but it's out there. This is just a cartoon that China tries to justify how resveratrol is active in Alzheimer's disease, and it's too complicated for me to understand. Green tea, the EGCG in green tea, also has been shown to inhibit the neurodegeneration, the damage to the nerves in Alzheimer's disease, and protects rat brain, good news for rats, from Alzheimer's toxicity. And also at low doses, it's an anti-inflammatory, and those abbreviations there are some of the chemicals that go up when there's systemic inflammation. And it stabilizes the tetramers of the TTR molecule. We'll talk about D-flunisol momentarily. And it's been shown to, again in the test tube, inhibit the formation of amyloid fibrils, and it promotes the breakdown of existing amyloid deposits. Green tea has been used both in ATTR as well as AL amyloidosis. There have been a number of studies, including small trial of 14 patients with ATTR cardiomyopathy who took a year of green tea extract, and that showed no change in echo and some decrease in the total amount of heart tissue by MRI. But as you heard from Dr. Ruberg, the reproducibility of MRI from center to center to center can be a little bit problematic, so a grain of salt with that. AL is not the subject of today's meeting. It's a different type of amyloidosis, but they looked at 59 patients taking similar doses with AL treatment, so it wasn't just by itself. And AL treatment usually involves chemotherapy, which is not used in ATTR. And what they showed is some reduced thickening of the heart walls. Again, Dr. Ruberg emphasizes how you put the little measurements in the green dots and you get different readings. And so it's a little hard. And here is some of the data from AL. Again, this is different from ATTR heart disease, suggesting some benefit. Another study that was published 5 years ago looked at ATTR cardiomyopathy at a amyloid center in Florence. And 30 patients were treated with green tea and were followed up for just under 2 years. And more people died in the green tea group than in the non-green tea group. This is not hard science with small numbers here. And that wasn't a significant difference. D-flunisol is very, very different because this really did, led by Dr. Berk, undergo rigorous study. And D-flunisol was developed by Jeffrey Kelly, a basic scientist who's spoken at this meeting from the Scripps Institute in San Diego. And D-flunisol is an NSAID, like Motrin, like Aleve, that stabilizes TTR. Now, it is not approved for the treatment of that, but that's just, all that means is no drug company decided to go forward with the FDA to make an application. And of course, the only approved treatment for, well, now we be soon too, but the only stabilizer approved for treatment right now is tafamidis, Vyndaqel, and likely in the near term, acoramidis will be approved, AG10. But those aren't available globally and aren't available to every single patient that's eligible to take it. And some of that involves insurance, and you're going to be hearing about that issue in about 2 hours. But what Dr. Berk did is he did a very careful trial looking at D-flunisol in TTR amyloid neuropathy, the inherited type, not cardiomyopathy, and gave a half a tablet twice a day. And what he demonstrated is that there was much greater deterioration, and this is a well-done study, in patients who didn't take D-flunisol, they were on a placebo, versus those that took D-flunisol. Now, this is not necessarily a substitute for tafamidis, acoramidis, or the imminent approval of new gene silencing therapies for inherited amyloid. But again, everybody can't access these all over the world. This is a legitimate alternative, and I'm sure that every neurologist and cardiologist has prescribed this for patients who weren't able to access the more traditional agents. And so D-flunisol does inhibit neurologic progression in people with TTR and preserves their quality of life. And it's an NSAID, so you have to monitor kidney function, and some people may retain a little salt, so you're working with your cardiologist to be sure it doesn't make anything worse. But I'm going to have to tell you, in my experience, the majority of patients tolerate this quite well. And like other NSAIDs, you have to watch for stomach irritation because it can have an irritant effect on the stomach. When do you consider one of these alternative agents? Well, one time you could consider it is when there really isn't any approved alternative. So, for example, patients who are asymptomatic carriers, they know they've got the gene but have never developed any symptoms. We have no approved treatments. The question is there any value in using some of these agents in a preventative role? And, you know, amyloid starts when the TTR starts to misfold, but nobody knows how to measure it. The best we can do is just measure when people start having numbness in their feet or carpal tunnel syndrome or shortness of breath or fluid retention. And so we depend on a very late signal, and that's organ malfunction, and that's already well advanced in this disease, but that's when you get approval to use these agents. So Dr. Berk says what to do, and it's established the onset of the earliest manifestations of amyloid. So that's in TTR, watching for carpal tunnel syndrome, which can precede the development of heart amyloid by 8 years on average, loss of feeling in your feet, low blood pressure, which can be your nerves or your heart, the development of unexplained diarrhea, which are those automatic nerves that control the intestinal function, and shortness of breath, which usually is an early manifestation of a reduction in heart efficiency. TTR levels, prealbumin is TTR, can be measured in the blood. In patients who take gene silencing treatment, you can actually see the TTR levels fall. And in patients who take stabilizers, you can see the TTR levels rise. Those can be measured. They're not proven endpoints, but it is something I tend to follow in my patients just to know that the treatment is doing what I think it's supposed to be doing. A consideration of green tea. Nutraceuticals are an option, but their absorption is poor. And the questions that we'll reserve for this afternoon and tomorrow is, if you have someone who's a known gene carrier, a sibling, an uncle, an aunt, a child, would beginning a protein stabilizer before disease help or hurt people? I will tell you that there is a proposed trial that hasn't been activated looking at patients who are known to be at risk of hereditary TTR amyloid but have no symptoms at all. And that is going to be activated. So you'll hear about it through Muriel and the website when that activates. And then, of course, if someone has TTR carpal tunnel syndrome but no amyloid in their heart, is there any role to consider some type of preventative measures at that point in time? And then questions for our panel tomorrow about how we manage patients who are found to have TTR amyloid in the carpal tunnel, but nothing else. So with that, I'm going to thank you, and we're going to move on.